Hello everyone, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant in Bangalore, and I have an experience of teaching undergraduate and postgraduate medical students. I have done my MBBS and MD from Rajiv Gandhi University of Health Sciences. So today we'll be discussing about micronutrients, especially vitamin A, B complex, and vitamin C. Okay, so this is a very important topic. There are a few syndromes also to keep in mind. So before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform and there are a lot of benefits you can avail. Firstly, there are live classes. You can chat with your educator, you can attend their daily classes and engage in the discussion, ask your doubts in the live chat box and will be cleared immediately. Okay, also whenever you're preparing for any entrance exam, you need to have a structured course. You need to plan, and for NEET PG being 1 year, you had to plan the entire preparation for the entire 1 year. And in Unacademy, we provide you with these structured courses in line with your exam syllabus. Also, this will be a big boost for your preparation, and also it will help you in a great way. Also, whenever you're preparing for your preparation, you need to analyze yourself. You need to know what are your weak areas, what are your strong areas. With these live tests and quizzes, which we provide here in Unacademy, you can evaluate yourself and you can concentrate on your weaker areas better. Also, once you subscribe to the subscription, you get unlimited access to all the classes. So the live classes as well as the recorded classes. Even if you have missed any live classes, you can go back to the subscription and watch the classes again and again. So you do not miss on anything. Okay, all this from the comfort of your home and comfort of your own devices. So daily classes are there with different educators. You can choose your favorite educator and you can watch the classes. Also, these are our top educators. So they have classes regularly on the platform. Please do go watch their classes. And these are the courses provided. For NEET preparation, you have 19 subjects to prepare, and all these subjects are taught in this platform by the top educators. And these are the ongoing courses in our platform right now. Coming to the subscription package, we have subscription package ranging from 1 month to 2 years. I would suggest the 1 year and the 2 year subscription, as NEET PG preparation is a 1 year long preparation. So taking a 1 year or 2 year preparation package will be reasonably feasible also. Okay, so 1 year subscription costs you around 25,000, but if you use my code Shilpa10, you get a 10% discount and it will come up to 22,500. Okay, and if it's a 2 year subscription which you are taking, it will come up to 30,000, but using my code Shilpa10, you get a 10% discount and it will come up to 27,000. Okay, so this is a very reasonable price and it is very reasonable compared to other platforms. And using this platform in the early part of your preparation will take you a long way. So I would highly recommend it, and you should also use it. Okay, so coming to today's topic, so firstly I will talk about vitamin A micronutrients. So yeah, so vitamin A is a obligatory, so it has to be provided in the diet. Okay, so as you all know, vitamin A is very important for us. So what are the functions vitamin A has in our body? So firstly, So vision is needed for the pigments in the retina, rhodopsin, iodopsin, and in the reproduction, thirdly, for the cell and tissue differentiation, fourthly, for the immune system, to improve the immune system. It is also important in the neonatal development, in the embryonic development also. So deficiency of vitamin A can cause uh, problems in any of these uh, areas. The sources, so animal sources, especially in the organ meats like liver and kidney. Other animal products like meat, milk, cheese also have moderate levels. Okay, so in vegetables, you get access to all these red to orange color fruits and vegetables and green leafy vegetables. Okay, so they are rich in alpha carotenoids, beta carotenoids, and beta cryptoxanthin. But beta carotenoids is more very important. Carotene is very important. So these are precursors which leads to the formation of essential metabolites. Okay, what are the essential metabolites of vitamin A? So firstly, it is all trans retinoic acid. Retinoic acid. And second, it is 11 cis retinal. Okay, so all trans retinoic acid is important in cell and tissue differentiation, and in gene transcription, while 11 cis 11 cis retinal is important for the vision. Okay, yeah. Coming on to the deficiencies. Okay, so what are the features, changes it can cause in the mucous membrane and skin? So in the intestine, the mucus secreting epithelium, okay, is very essential to trap the pathogen and uh, the not to cause diarrhea. And same like even in the respiratory epithelium, there is mucus secreting epithelium, which is very important for the disposal of the pathogen. But if there is vitamin A deficiency, what can happen? There can be proliferation of the basal cells, hyperkeratosis. So this leads to the formation of stratified, cornified, squamous epithelium. So this squamous metaplasia, okay, so this squamous metaplasia can occur in the renal pelvis, in the ureters, in the vaginal epithelium, in the pancreas, in the salivary ducts, Okay, and this can in turn increase the risk of infection. Okay, so this is what happens in the mucous membrane. In the skin, there is dry, scaly, hyperkeratotic patches, keratotic patches. Okay, commonly in the legs, shoulders, and the buttocks. Okay, so the characteristic features in vitamin A deficiency is the eyes. Okay, so in the eye, one of the early presentations is having delayed dark adaptation. So delayed dark adaptation occurs because of decreased re, resynthesis of the pigment rhodopsin. Okay, so as the vitamin deficiency progresses in the late stages, it can present with night blindness. So in night blindness, what happens? There is absence of rhodopsin pigment. Absence of rhodopsin. Okay, yeah. Also, now this vitamin A deficiency persists. There can be mm, yeah, there can be keratinization of the cornea, that is called xerophthalmia. Then it can lead to keratinization of the conjunctiva, leading to white spots. Okay, so this can further lead to keratomalacia. If it is not treated, keratomalacia, corneal ulcers, and if not treated, it can lead to blindness. Okay, what are the other clinical signs? So there is clinical features. There is growth retardation, repeated infections. Okay, anemia, mental retardation, apathy, increased intracranial pressure. Okay, so all this can happen. Okay, so that is why it's very important to be supplemented with vitamin A. So this is a WHO classification of xerophthalmia. What are the primary signs? So first there will be conjunctival xerosis. Okay, dryness, then leads to white spots. There will be corneal xerosis. Then if there is X3A, if the corneal ulceration is less than one third of the cornea, it's corneal ulceration. Then if it is X3B, that means more than one third of the cornea is involved. So what are the secondary signs? There can be night blindness, there will be fundal changes, and there will be corneal scarring. So how do you treat a child with vitamin A deficiency? So if there is vitamin A deficiency, if the child is less than 6 months, you supplement with 50,000 units of vitamin A, and if the child is between 6 to 12 months, you supplement with 1 lakh units. If it is more than 1 year, that is more than 12 months, that is you give 2 lakh units. So this is given on day 0, day 1, and after 4 weeks. Okay, so if there is any absorption conditions, then you can give vitamin A parenterally, IV. So IV dose will be uh, half, half the dose for children between 6 to 12 months, 50% of the dose, while for children less than 6 months, it will be 70% of the 75% of the dose. Okay, so it will be 75% of 50,000 50,000, and it will be 50% of 1 lakh. Okay. So now coming to thiamine. Thiamine is also vitamin B1. It is the active form of thiamine is thiamine diphosphate. Okay, it is a cofactor in a lot of for several enzymes which are involved in carbohydrate catabolism. Okay, so that is what? Pyruvate dehydrogenase, transketolase, and alpha ketoglutarate. Okay, so thiamine is required also for the synthesis of acetylcholine and GABA. So they are very important for nerve conduction, as you all know. Okay, so if there is generally the thiamine is well absorbed in the gut, but if there is any abnormality in the GIT and the liver, that can lead to thiamine deficiency. So what are the sources? So meat, fish, chicken, rice, oat, wheat, and legumes. These are rich in vitamin thiamine. So repeatedly washing the rice and repeatedly washing the rice before cooking, I mean throwing off the water of the rice can lead to deficiency in the thiamine. So always, how do we parboiling the rice helps in preventing that deficiency of thiamine in the rice. So there is something called as thiamine responsive megaloblastic anemia. So this is associated with anemia, diabetes mellitus, and megaloblastic anemia. Sorry, diabetes mellitus, megaloblastic anemia, and sensory neural hearing loss. Okay. Okay, so this happens because there is mutation in this gene, that is SLC19A2. So this gene codes for the thiamine transport protein. Okay, so because of this mutation in this gene, there is defect in the thiamine transportation, and as a result, there is diabetes mellitus, megaloblastic anemia, and sensory neural hearing loss. So giving replacing with thiamine gives a very good response in this defect. Okay. Okay, so how does the child with thiamine deficiency present? So in the early stages, it is very vague. Okay, vague symptoms like fatigue, anorexia, nausea, vomiting, depression, okay, and poor mental concentration. But as the in the later stage, as it progresses in the later stages, it can present with features of beriberi. What are the features of beriberi? So it will be peripheral neuropathy. So this will have a tingling, burning sensation of the toes and the feet. So decreased deep tendon reflexes, loss of vibration sense, there can be cramping of leg muscles, heart failure. Okay, there can be psychological disturbances. There could be ptosis of the eyelid, atrophy of the optic nerve, optic nerve. Okay, so all these are the features. So thiamine deficiency, that's which leads to beriberi. Beriberi can be divided into two. Okay, wet beriberi and dry beriberi. Wet beriberi presents with cardiac symptoms. Okay, while dry beriberi is more of a neuritic type. Okay, yeah. So, in thiamine deficiency, there is something called as Wernicke's encephalopathy. So, in Wernicke's encephalopathy, there's a triad. So, there will be mental changes, okay, ocular signs, and ataxia. Okay, so so this you need to know. Wernicke's encephalopathy, you need to know. So, in children with thiamine deficiency, the cause of death is generally cardiac. So these children can have tachycardia, cyanosis, dyspnea, convulsions. But if the child is treated at the right time, okay, the treatment should be very aggressive. If you treat, this can all be reverted. Okay, but if it's not treated, then the progression to death also is very fast, and then the child can die of cardiac failure. Okay, so the ECG changes in thiamine deficiency include prolonged QT interval, inverted T waves, and low voltage waves. So you all can get a question like, what are the ECG changes in thiamine deficiency? I mean, all of the following are the changes in thiamine deficiency, ECG changes in thiamine deficiency, except, so they can give prolonged QT interval, inverted T waves, low voltage waves, and something else. So that you should know. Okay. Yeah. So next, how do you diagnose? So this is whenever a child comes with cardiac failure, you should always keep in mind thiamine deficiency. Okay, that's where thiamine deficiency. So no secondary causes, but the child has come with sudden onset of cardiac failure. All that should be kept in mind. Also, you can evaluate erythrocyte transketolase activity and uh, thiamine pyrophosphate effect. Okay, any erythrocyte transketolase activity being low and a high thymine pyrophosphate effect leads to the diagnosis of thymine deficiency. Okay. Okay. Also, now if you give in a child with thymine deficiency, if you give thymine and if there is presence of thymine metabolites in the urine, that in urine, that is thiazole or pyrimidine. This also helps in the diagnosis of thymine deficiency. So one is prevention. How I told paraboiling is an paraboiling helps in prevention. Okay, paraboiling of rice. How do you treat a child with thiamine deficiency? So in a child who is in a very serious condition like cardiac failure or in coma or something, in a severe critical condition, you give 10 mg of IV or IM thymine for 1 week. Then you change to 3 to 5 mg of thymine orally, uh, orally for at least 6 weeks. Okay, so this is the treatment for thymine. So thymine. Riboflavin. Yeah, riboflavin. So riboflavin is part of a structure of the coenzyme flavin adenine dinucleotide and flavin mononucleotide. Okay, so this is involved in a lot of oxidation reduction reactions in a numerous pathways. So what are the sources? Okay, they are present in milk, eggs, organ meats like kidney, liver, legumes, mushrooms. Okay, so there is something called as brown violletto von Lery syndrome. Okay, so this is characterized by it's a neurologic disorder. It is characterized by, it's a neurologic disorder. Okay, this is characterized by progressive neurologic deterioration, hypertonia, and sensory neural hearing loss, frontobalbar palsy. Okay, this responds to treatment with riboflavin. So why this happens? This happens because of the mutation mutation in the riboflavin transporter gene. The proteins. So mutation in the riboflavin transporter protein causes Brown-Violletto von Lery syndrome, which is a neurologic disorder. So how does it present with? It's a progressive neurologic. There is a progressive neurologic deterioration. There is hypertonia. There is pontobulbar palsy. Then there is sensorineural hearing loss. The child treatment with riboflavin gives very good results. Okay. So if the child presents with riboflavin deficiency alone, okay, there is no mutation in the riboflavin protein, basically deficiency in the poor intake or poor absorption of riboflavin. So how does it present? So there is chelosis, glossitis, keratitis, all the mucous membrane lining is, conjunctivitis, corneal vascularization, seborrheic dermatitis. So here all the mucosal say most of the vitamin B complex deficiencies, the skin and the mucous membrane, all the vitamins actually, the skin and the mucous membrane is generally involved. Okay, so always keep that in mind. So dermatitis and the mucositis also is involved. Okay, so here chelosis, glossitis, keratitis, conjunctivitis, corneal vascularization, seborrheic dermatitis occurs. Okay, also there can be impaired erythropoiesis, which leads to normochromic normocytic anemia. Yeah, normocytic anemia. So how you diagnose? Okay, so there is something called as erythrocyte glutathione reduction. glutathione reductase, and there is a, that is, I will write it as EGR, and then there is a erythrocyte glutathione reductase coefficient. Okay, if this erythrocyte glutathione reductase of more than 1.4, so basically erythrocyte glutathione reductase by what is it, flavin adenine dinucleotide gives the erythrocyte glutathione reductase. So if any value more than 1.4 gives a diagnosis of riboflavin deficiency. Okay, so how do you treat? Hmm? How do you treat the child with this thing? The treatment is by replacing the loss with riboflavin. You give 3 to 10 mg per day of riboflavin. Okay, so this 3 to 6 months, then there will be reversal of the symptoms. Next, coming to niacin. Okay, niacin forms two cofactors. Okay, vitamin B3. Two cofactors. One is nicotinamide adenine dinucleotide, and another is nicotinamide adenine dinucleotide phosphate, NADP. So these are very important. These are very important in respiratory chain, fatty acid, and steroid synthesis. Fatty acid and steroid synthesis. Then in DNA processing. Okay, niacin. Niacin can be produced from tryptophan also. Tryptophan. So if the diet has high rich tryptophan, so that can be converted into niacin also. Okay, so what are the sources? So meat, fish, poultry, cereals, legumes, green leafy vegetables. Okay, so these are the sources. So how does a child with niacin deficiency produce? Okay, so as you all know, that when there is niacin deficiency, the child presents with pellagra. Okay, so this is pellagra is seen in kind of places where corn, maize is the staple food, which is deficient of which is a poor source of tryptophan. So there you see pellagra. So pellagra has a triad. Okay, you all should be knowing this: dermatitis, diarrhea, and dementia. So dermatitis, how does it present? So it presents, say in the beginning, people think it is just photosensitivity, and slowly there will be erythematous demarcated areas in the sun exposed areas. So in the neck, it is called as castle necklace. Okay. Also, the nervous symptoms like dementia, disorientation, insomnia, and delirium can present. Okay, and diarrhea also, diarrhea and constipation can alternate in a child with pellagra. Okay, so how do we diagnose? So one is with the treatment with niacin, there is a rapid improvement, rapid clinical improvement. So this confirms the diagnosis. Another is niacin metabolites in the urine. The niacin metabolites are N prime methyl nicotinamide, and 2 pyridone, okay, present in the urine. These are the urine niacin metabolites. So, if you get a histopathology of the skin, histopathology examination of the skin, it can show ballooning of the keratocytes, hyperkeratosis, and epidermal necrosis. Okay, so how do you treat a child with pellagra? Okay, you give 50 to 300 mg of niacin. So this is in severe cases. And 100 mg IV if there is malabsorption. Fine. Next, coming to pyridoxine. So pyridoxine, the features include, so pyridoxine is essential. So it's a coenzyme in amino acid metabolism. It is needed uh, in the neurotransmitter synthesis, glycogen metabolism. Okay. So what are the sources? Uh, so so you see, it needs to be fortified in, if the child is in infant formula. So in rice, the legumes, poultry, you get there is enough pyridoxine. Okay, what are the risk factors of pyridoxine deficiency? People on drugs like isoniazid, penicillamine, corticosteroids, phenytoin, carbamazepine. You see, these are important. This is important. So, what are the risk factors? Remember this: what drugs which can cause pyridoxine deficiency? So, isoniazid, penicillamine, corticosteroids, phenytoin, carbamazepine. Also, in women who are on progesterone, progesterone, estrogen contraceptives. Okay, and patients who are on dialysis. Okay, these are the risk factors. Okay, how do these children present? Mostly, they present as with neuritis, so peripheral neuritis. Okay, then again, skin and mucosal lesions like chelosis, glossitis, seborrheic dermatitis. Okay, and oxaluria, hyperglycinemia. So, how do you diagnose? So here you see erythrocyte, transaminases, glutamic, oxaloacetic, transaminase, and you see the activity of these erythrocyte glutamase, glutamic oxalate transaminase, and glutamic pyruvate transaminase. So their activity is decreased. So how do you treat? So you give an intramuscular or an IV administration of 100 mg of pyridoxine. Okay, so and the children who are dependent, a daily dose of 10 to 100 mg orally of pyridoxine. So children who are on isoniazid, you have to supplement with pyridoxine. Okay. Next, coming to biotin. Biotin is a cofactor for various enzyme reactions. Okay, cofactor. So how and generally biotin is available in most of the uh, food. Okay, animal, it could be animal origin or plant. So very rarely do you find biotin deficiency. But people who take raw egg, the whites of the raw egg, whites of the raw egg contains avidin, which inhibits biotin. So biotin deficiency is in people who take a lot of raw eggs. Okay, so these patients, yeah, so these patients present with scaly orificial dermatitis, conjunctivitis, thinning of hair, alopecia. Okay, so giving a treatment with 1 to 10 mg of biotin orally, it's the treatment. Okay, so there is something called as biotin responsive basal ganglia disease. A disease. Okay, so here this is a rare childhood neurological disorder. This has encephalopathy, seizures, and extrapyramidal manifestation. So these are all very rare things, but just keep in mind if it turns out to be a bouncer. Okay, folate. The folic acid again is it, it is a part of a lot of metabolic reactions in the body. Reactions. Okay, the sources are, it is present in rice and cereals. Okay, low levels of folate has been associated in pregnant mothers, have been associated with neural tube defects, right? Yeah. So the deficiency of folate presents with anemia, that is megaloblastic anemia. Okay, folate is very important for the DNA and RNA synthesis, and it can lead to it can affect the cellular, cellular metabolism. Okay, then uh, yeah, so mainly it is anemia, and that itself can cause associated conditions. How do you treat? How do you treat? You treat with zero point 0.3 to 1 mg of folate, zero point 0.5 to 1 mg of folate. So there is something called as hereditary folate malabsorption. Okay, so it is presented in between children of 1 to 3 months, and they will have chronic diarrhea, failure to thrive, okay, and oral ulcerations and anemia. So treatment is give folic acid. And another thing, there is cerebral folate deficiency. So cerebral folate deficiency, it presents with children between 4 to 6 months. There is microcephaly, there is developmental delay, there is cerebral ataxia, then there is pyramidal tract signs. Okay, there is balismus, then the sensorineural hearing loss, there is blindness. So here the 5 prime methyl tetrahydrofolate levels are normal in the serum and the urine, but when you get a CSF analysis done, it is decreased. So that gives you a diagnosis of cerebral folate deficiency. Okay, and I've told you treatment is 0 0.5 to 1 mg per day of folate for 3 to 4 weeks. So even cobalamine is again uh, in a lot of metabolic reactions. Diagnosis, you get the serum levels done. Okay, so clinical features similar to megaloblastic anemia. They present with anemia and tremors, peripheral neuritis, feral neuritis. Okay, so treatment includes supplementation. So around 1,000 micrograms should be given based on the severity. If it is very severe, you give daily or alternate doses, then weekly for a month, and then once 3 months, then every 6 months. Okay, but this should be followed by this should be supplemented with oral. This what I'm talking about is IM. Okay, but but the IM injections should be supplemented by orally supplementation of addition of vitamin B12. Another important vitamin is vitamin C. Okay, so vitamin C is very important in collagen synthesis. Okay, it is also involved in the conversion of dopamine to norepinephrine, also conversion of tryptophan to serotonin. It is important in cholesterol metabolism. So basically conversion of cholesterol to steroid hormones and bile acids. So this is a very important vitamin, and also vitamin C is an antioxidant. Okay. Okay. So sources include citrus. The citrus fruits are very rich in vitamin C. Okay, the lemon, oranges, okay, sweet lime. So how does a child with scurvy, that is vitamin C deficiency, is called scurvy, present with? So initially they present with irritability, loss of appetite, okay, musculoskeletal pain, pain. Okay, there can be swelling of the leg and can present as pseudo paralysis. Okay, then and there can be subperiosteal hemorrhage. There can be a swelling because of this hemorrhage. They can present as swellings. Okay, there again at the costochondral junction there is thickening. This is called as scorburatic rosary. The scorburatic rosary is more thicker than compared to rachitic rosary. So at the junction of the costochondral junction, so the where the rosary, the thickening happens, it's more thicker and it's more angular in case of scurvy. Okay, they also present with anemia. Then the gums are thickened. Okay, we can have petechiae, purpura, ecchymosis. Okay, so diagnosis. Um, diagnosis is done clinically and with the diet history, and also if you get an X-ray done, uh, the distal part, the distal ends of the long bones are affected. The commonly involved site is the knee. So if this is the end of the okay, okay. If this is the end of the femur, okay, in a child, so this is the epiphysis, and this is the proximal end of the tibia. So first of all, the shaft of the bones have a ground glass appearance. Shaft is a has a ground glass appearance. Okay. Now the cortex is thin, and as a result, so cortex is thin. So the outline looks like a pencil outline. Okay. So a pencil outline. Okay. Next, coming to the white line of Frankel. So at the end of the metaphysis, there is a white line like this. So now with though I'm marking in black, but in the X-ray you can see a white line at the end of the metaphysis. So this is called as the white line of Frankel. Okay, and this is the epiphysis. So the epiphysis has inside has a ground glass appearance, but it is surrounded by a sclerotic ring. Okay, so this is called as the Wimberger's ring. And then, as I've said over here, there is a this is a cortex. There's a ground glass appearance. Okay, so there is this area like this. So this space in the X-ray, it will be shown as black. It looks like there's a break in the bone. So this area, which on the X-ray will be black, is called as the this entire area. Okay, in the X-ray, so just above the white line of Frenkel, you can see a black zone on the X-ray. So that area is called the zone of rarefaction. So that is called the Trummerfeld zone. Feld zone. Okay, and this next, the white line of Frenkel, if it prolongs laterally, then it is called the Falcon spur. So these are the features what you see on X-ray. Okay, so a child, so I'll again show it in the later when we have a recap. So the treatment for vitamin C is 100 to 200 mg orally or parenterally. Okay, and the child he recovers in 3 months of treatment. Okay, so this is what, so today we have discussed. Yes, today we have discussed vitamin A, B complexes, and vitamin C. Okay, yeah. So vitamin A, as I've said, it's an obligatory dietary factor, and it is important for the vision, reproduction, cell and tissue differentiation, and for the immune system. They're also very important for the neonatal development and embryonic development. So what are the sources? There is animal source that includes organ meats, okay, which is very rich in vitamin A, that is the liver and kidney, and the meat, milk, and cheese have moderate levels of vitamin A. Then the red to orange fruits and green leafy vegetables also have a vitamin A. So vitamin A in the form of beta carotene, alpha carotene, and beta cryptoxanthin. So beta carotene is very important. So these precursors, beta carotene, the alpha carotene, and the beta cryptoxanthin, they give essential metabolites of the vitamin A. So the what metabolites? They are all trans retinoic acid and 11-cis retinol. So the all trans retinoic acid is very essential for the cell and tissue differentiation and gene transcription, while 11-cis retinol is important for vision. Okay, so I think we've understood this much. So this is a revision again before everything evaporates. Okay, so vitamin A deficiency. So vitamin A, as I've told you, it is important for cell and tissue differentiation, immune system, vision, and reproduction. They are seen in the changes in the mucous membrane and the skin. There are eye changes. There are other clinical changes like the growth retardation. There will be repeated anemia. This mental retardation, apathy. There is increased intracranial pressure, and there is, it can be repeated infection. Okay, so what are the changes you see in mucous membrane and skin? So in the mucous membranes, like in the GIT and the respiratory epithelium, there is proliferation of the basal cells. Then there is hyperkeratosis. So this leads to stratified cornified squamous epithelium. So that is squamous metaplasia. So this squamous metaplasia occurs in a lot of other places, in the renal pelvis, in the ureters, in the pancreas, in the duct lining. So these areas can have repeated infections. Okay, in the skin can have a dry, scaly, hyperkeratotic patch. Okay, eye changes. So the early symptom is there is a delayed dark adaptation. That is because there is decreased resynthesis of rhodopsin. Okay, in the late feature is there is night blindness. There is absent night blind. That is because there is absence of rhodopsin. Okay, so coming to the WHO classification of xerophthalmia. So what are the primary signs? Okay, primary, so this you've seen in guy, OP guy. So X1A leads to, first is conjunctival xerosis, then there is Bitot spots. So this even bypass in the conjunctiva. So from conjunctiva it goes to the cornea. So corneal cirrhosis, then corneal ulceration. So if there is less than one third of the cornea involved, then it is called X3A. But if the corneal ulceration is more than one third of the cornea involved, then it is X3B. So what are the secondary signs? There could be night blindness, there is fundal changes, and there can be corneal scarring. How do you treat a child who has vitamin A deficiency? If the child is less than 6 months, you give 50,000 units. Then at 6 to 12 months, you give 1 lakh units, and for more than 1 year, you give 2 lakh units. So this is given at day 0, that is at the time of presentation, and the next day, and at 4 weeks. Okay. So if there is a child who has malabsorption, then you give it IV. So IV, how do you give for a child who is 6 to 12 months? That is 1 lakh unit is given 50% of the dose, and for a child who is less than 6 months, you give 75% of the dose. Okay. Okay, now thiamine deficiency. So thiamine, the most active form of thiamine is thiamine diphosphate. Okay, so it is a cofactor in a lot of in carbohydrate catabolism. That is pyruvate dehydrogenase for transcrystallase alpha ketoglutarate, and it is important in the synthesis of acetylcholine and GABA, which are important in nerve conduction. So there is something called as thiamine responsive megaloblastic anemia. So it presents with diabetic mellitus, megaloblastic anemia, and sensorineural hearing loss. So as I've said, it is because of the mutation in the gene SLC19A2. Okay, that codes for thymine transporter protein. So there is a defect in the transportation of thymine, which results to this thymine responsive megaloblastic anemia. So giving thymine, so treating with thymine has a very good response, and the anemia improves. And so now a child with no mutations, but because you have deficient intake of thymine, can present with uh, beriberi. So in the early stages, it is vague. The symptoms are vague. It can present with anorexia, nausea, vomiting, depression. Okay, but as in the later stages, that is signs of beriberi. So child can present with peripheral neuritis, decreased deep tendon reflexes, loss of vibration sense, there is cramping of the leg muscles, then there could be heart failure, there could be psychological disturbances, there could be ptosis of the eyelids, and the atrophy of optic nerve. Okay, again in thymine deficiency, it is divided into two. So if a child presents with more of cardiac symptoms, it is called wet beriberi, and more of neuritic symptoms, it is called as dry beriberi. But most of the time, beriberi is in a mixed presentation. So generally they call it as thymine deficiency with encephalopathy, with peripheral neuritis and cardiomyopathy. Okay. Okay, in children who have the beriberi, more the death is due to cardiac failure. Okay, so initially child can present with cyanosis, dyspnea, tachycardia. If the child is treated immediately with thymine, it can revert back. Okay, but if the child is not treated, then cardiac failure, then the cardiac failure will soon ensue, and can be death of the child. Okay, what are the ECG findings in a child with thymine deficiency? There is prolonged QT interval, there is inverted T waves, and there is low voltage waves. Okay, and there is this Wernicke's encephalopathy is associated with thymine deficiency. It presents with a triad, that is mental changes, that is ocular signs, and ataxia. Next, the diagnosis of thymine deficiency. So you measure the erythrocyte transcriptolase activity, okay, and the thymine pyrophosphate effect. So if the erythrocyte transcriptolase activity is decreased and there is increase in the thymine pyrophosphate effect, then you can diagnose thymine deficiency. Okay, so thymine metabolites in the urine. If there is thymine metabolites in the urine in a child with thymine deficiency, that is thiazole and pyrimidine, again it gives a diagnosis of thymine deficiency. Parboiling of rice helps in prevention of thymine deficiency. So treatment, as I've told earlier, 10 mg of IV or IM thymine for 1 week. This is in serious conditions. Okay, then this is followed by 3 to 5 mg of thymine orally for at least 6 weeks. Now coming to riboflavin. Riboflavin is again very important in a lot of reactions in the body. The sources they are so as shown. So there is this Brown-Violletto Van Lery syndrome. This is a neurological disorder. Okay, so there is progressive neurological deterioration, there is hypotonia, then there is sensory neural hearing loss, pontovalvar palsy. So why does this happen? There is mutation in the riboflavin transporter protein, and as a result this happens. So remember this Brown-Violletto Van Lery syndrome. Okay, BVVLS. So the treatment for this is again riboflavin. So now again, the clinical features of riboflavin deficiency. So this is basically what I'm saying is a deficiency due to poor intake. Okay, so children present with chelosis, glossitis, keratitis, conjunctivitis, corneal vascularization, seborrheic dermatitis, impaired erythropoiesis. This can present with normocytic normochromic anemia. When you diagnose a riboflavin deficiency, erythrocyte glutathione reductase, okay, or the erythrocyte glutathione coefficient. So this is with the flavin adenine dinucleotide. So if that is more than 1.4, a riboflavin deficiency is diagnosed. Treatment is 3 to 10 mg of riboflavin every day, and also to improve your diet. Niacin. So niacin is very important. It it acts by it forms two cofactors. One is nicotinamide adenine dinucleotide, one is nicotinamide adenine dinucleotide phosphate. Okay, so they're important in the respiratory chain, the fatty acid and steroid synthesis, and DNA processing. So they can also be formed from tryptophan from your diet. So if there is tryptophan in the diet, so that gets converted to niacin. So the deficiency of niacin is called pellagra. So pellagra has a classic triad, that is dermatitis, dementia, and diarrhea. Okay, so pellagra is especially seen in places where corn corn is the staple. So corn is poor in tryptophan, and that doesn't get converted to niacin. Okay. Okay, niacin, N-methyl nicotinamide and 2-pyridone, which are present in the are the niacin metabolites, and if they are present in the urine, uh, you have to check for niacin deficiency. Treatment, as you've seen, 50 to 30, 300 mg of niacin is given in severe cases, and 100 mg IV is given in malabsorptive cases. Pyridoxine is a coenzyme in amino acid metabolism. It's a coenzyme for neurotransmitter synthesis and glycogen metabolism. Okay, risk factors for pyridoxine deficiency. So patients who are on isoniazid, penicillamine, corticosteroids, phenytoin, carbamazepine, girls who are on progesterone, estrogen, contraceptives, and patients who are on dialysis are risk factors for pyridoxine deficiency. So the clinical features present with peripheral neuritis, chelosis, glossitis, seborrheic dermatitis, oxaluria, hyperglycinemia. Okay. Biotin. So biotin, as I've said, it's present in most of the food items, and as a result, the deficiency of biotin is very rare. But people who take a lot of raw eggs, the white in the egg has avidin, which inhibits biotin. So people who take a lot of raw eggs might present with biotin deficiency. So how do they present? There is scaly periorificial dermatitis, conjunctivitis, thinning of hair, alopecia. So treatment is 1 to 10 mg of biotin. Okay, there's something called as biotin responsive basal ganglia disease. So they can present with encephalopathy, seizures, extrapyramidal manifestations. So again, folate deficiencies. Folate is also vitamin B9. So this is very important for various metabolic reactions. The sources include rice and cereals. So low folate in pregnancy can cause neural tube defects. Okay, they present with anemia, affect cellular metabolism, and there is something called as hereditary folate malabsorption and cerebral folate deficiency. So hereditary folate malabsorption presents at 1 to 3 months, while cerebral folate deficiency presents at 4 to 6 months. Cobalamine is similar to folate. So coming to vitamin C, okay, vitamin C is important in collagen synthesis, and they are very important in certain neurotransmitters or formation of neurotransmitters. So it helps in the conversion of tryptophan to serotonin. dopamine to norepinephrine. It is helpful in cholesterol metabolism. So it helps in the conversion of cholesterol to steroid hormones and bile acids. They're very rich in citric fruits. Okay, so yeah, so this is again, like, once again I will explain the radiological features. Okay, fine. So if this is the lower end, so this is the lower end of the femur. So first of all, the shaft has a ground glass appearance, and since there is thinning of the cortex, this appears like a pencil lining outlining. Okay, then there is a white line of freckle. So in the x-ray this will be this will be seen as white. Okay, so there will be increased thickness like this, so that is called white line of freckle. Then this is the epiphysis. There is a sclerotic ring. So inside this there is a ground glass appearance, but there is a sclerotic ring like this. This is called as a Wimberger's ring. Okay, and as I said, over here there is ground glass appearance. So there is one zone. There is a zone of rarefaction. So this zone, so this entire that white thing what you see, but in the X-ray you'll be seeing it as black. So that is entire this area is called as Trummerfeld zone. And this white line of Frankel, when there is a lateral elongation, so if there is a lateral elongation like this, okay, it's called as a Pelkin spur. Okay, so this is the features you see in vitamin C deficiency in a child with scurvy. So treating with 100 to 200 mg of vitamin C orally or parenterally will revert these changes and the child will feel better. Okay, so for today it was this much, and I hope you'll have understood. I've gone in very detail, a lot of very detail. I have gone through the topics. So just listening to this might be enough. So most of the topics in vitamin A, B complexes, and vitamin C are covered. So tomorrow I'll be talking about vitamin D, rickets. So rickets is a very important topic again. So there are a lot of I didn't want to shorten it in this class. So tomorrow I'll be doing a detailed a discussion on vitamin D rickets, and maybe a little bit micro like uh, minerals like calcium, selenium, a little bit on that. So tomorrow is more on rickets, and I hope today you've understood all what I've explained. And to subscribe to the subscription, use my code Shilpa10. You'll get a 10% discount, and let me know if you all have liked the class. Okay, good good luck for your preparation, and study daily. That is very important. Reading, studying daily, must. Keep be motivated, and it will help you.